company, and we can just give a founder and president of Sensory Tech. And I'm not going to waste time introducing Patrick. You've got his bio. He's going to introduce the company and so on. We were very pleased to provide some of the financial backing to Sensory Tech. And we've been very, very impressed with this company. And I think you'll see this is what I might call a more traditional sort of administrative healthcare business application, but taking advantage of mobile technology in the middle. And it's really, what's cool is not so much the technology, what's really cool is what it enables and the business model that it enables. So, Patrick.
Thanks so much, John. All right, hopefully everyone can hear me in the back. And as we just mentioned, we're flipping between a couple of formats here. So this is a PowerPoint that was made in Keynote, so hopefully there's nothing screwed up in it. And if there is, I'll just walk through everything. So as I mentioned, Sensory Technologies, who we are as a company, I thought it would make sense just to give everyone some perspective on how long we've been slugging this out, and really give you some context of how we got where we are, what we're doing, both with mobile tech, with web, and in the space we're working in, which is here in Canada, and as it would seem in this month, in the US as well, and moving towards Europe. And really, who are the people that are doing it, and what are the impacts? And then if I can, at the end, give you any insights I have from someone that's the perspective of someone who's started essentially in an incubator, a privately funded incubator, and crawled their way up and out, and found something useful, and proved it, and went all the way up to first revenues and onward and upward. So the company started in 2005. We actually started with the pretense of bringing U.S. mobile medical technology to Canada. So that's why we started. We started, I was consulting for a private healthcare company, and a lot of people don't realize that aren't in the space, and in the home care industry, home care service providers are no different than an American home care company or healthcare company. They're either for-profit or not-for-profit. They're fighting for market share. They're margin-driven, and they're doing that all across Ontario in the 14 LHINs or 14 CCACs. And they are kindred sisters and brothers to the U.S. model. So it's a very, very similar space that we're working in. The difference is the number of payors. Here, essentially, the CCACs are the payors. In the U.S., it's Medicare and Medicaid, and then split up into various insurers. So there's less payors here, but other than that, it's almost identical. They have the same challenges, they have the same problems. And the U.S. had adopted technology earlier on due to building complexity. That's what drove mobile adoption in the community healthcare space in the U.S. And that was the complexity of building, the complexity of the codes that the practitioners have to track as they want to get paid for the work they're doing. And so they were about a 10-year curve ahead of us. So we looked at bringing technology up. That changed. We ended up making our own systems. We were looking at the best case was an 80% code throwaway. So we decided to make our own systems. And by doing that, we realized that to do it inside of one of these healthcare companies that I was consulting for would put us at a great disadvantage to sell it to anyone else in the industry. So we spun off a company. And we spun the company off. And so the key people that are involved in that are for the most part, people that are deeply involved in the space. And that's probably pretty hard to see from where you are right there. There's myself. My background is project management. I do not have a healthcare background. It's military and business. Elaine Knight is the founder, or co-founder with myself. Elaine owns a private healthcare company. Sold the majority of her interests out to conglomerate growing in space. Andrew Matthews is our VP of Sales. He's a former director of sales from TELUS Health. So he's very, very well adept in the space. And Tom Sobat, who is our CTO, and we brought Tom on just in the last 2 years. Tom is an individual, and we talked about some of the parallels with the banking industry and where it's gone to where we're going. Tom's claim to fame, outside of what he's doing with us, is the mortgage industry. And who here has a mortgage? Out of your hand, who here's got a mortgage? Not one of you. Who had a brokered mortgage or has gone to a mortgage broker and knows what they are? 85% of Canadian mortgage brokerages run through the system you built. And that entire system was around taking the paper-based process of farming out mortgage applications to various lenders, having them come to a single place, work with the data sets on a similar process, streamline existing workflows, both enabling and actually created the industry as we know it today. And at the same time interfacing with large, big old back office systems, which are the banking enterprise systems, and draw parallels to the hospital industry with that. And make a process that up until that point was really, really a magical process to a run-of-the-mill type of a situation where you can have thousands of mortgage brokers sitting all over the place in the country. So we brought him on. So we're an application service provider. What we do is not sell software. We host and hold and vend the clinical data for the users, for the system users, for us. The trade name that works under is Community Care Manager Enterprise. So our real focus is home care and institutional avoidance. So we're really driving the demand that our greater health system has to keep people out of hospital, or if they're in hospital, to get them out. And that sounds a little cold, and I'll talk a little bit about some dark subjects. We talked about it in our office about the two bookends. Our two biggest areas that we work in is complex care pediatrics. So these are patients that are mechanically dependent on devices to live and are medically fragile. So these are kids, these are infants, children that are usually severely deformed at birth, are ventilated, are G-tube fed, are on a 24-hour care plan to stay alive, and they're discharged to parents. They're discharged home, and that's usually where they live. The other end of the spectrum is end-of-life, palliative care for adults. So we're talking about, ideally, we all wanted to project. We're usually talking about a ripe old age, dealing with comorbidities, multiple illnesses, a complex end-of-life process from a clinical standpoint, but with an overwhelming patient population that wants to be at home to death. And that's what we're not doing as a system. Right? When we look at what's happening in the hospital environment, the majority of people die in hospital. And it's not a sustainable path forward. And when we talk about who we are as a population in Canada, or actually the Western Hemisphere, the same bubble affects the US, Canada, pretty much anything post-war, World War II, Europe as well. So where did we start? So we're headquartered out of London, Ontario, out of London. We have an office here in Toronto, and we actually have a development office in Minsk, Belarus as well. So we do onshore and offshore development for our systems. Just to give you some perspective, does anyone here have a healthcare background? So there's a few people. Okay, so LHINs, the LHINs are the payor of the system. Right, so they're the purse string holders. There's 14 of them. They go across the province. They're regionally divided. The Southwest LHIN is London's in the middle of that. Toronto Central is right here where we're standing. They're all roughly the same population size, 1 million people, give or take, in each one of them. But there's variations between them based on geography and based on demographics, etc. So we're from the Southwest LHIN. What's interesting about the Southwest LHIN? That's Tobermory up at the top, right, if you're thinking camping. Down here is Lake Erie if you're thinking sick fish. I grew up down here, all right? There's London. London likes to think Toronto's not the center of the universe, and they're the center. But basically what you have is you've got an incredibly well-distributed rural area. This is like the Midwest US right here, right? That's, hopefully in the back you can hear me. I know I've stepped away from the mic. So what we actually have is a sandbox that represents a very, very good subsection of a huge part of the United States population. Where, unlike Northern Ontario, where you could be an hour between towns, you're no more than five minutes between each town. And the reality is, for the average person here that needs to get detailed care, they're coming down here. They're coming 2 hours to London, right? That's not the metropolitan Toronto reality, but that's the reality for the majority of Canada, unless you're living directly in the urban environment. To put that in perspective, there's, I believe there's about 13 different hospital sites in that LHIN. So it's actually not a small LHIN from an infrastructure standpoint. The London Health Sciences Center is a large facility. Who's using our system right now? Let's see if this is up in advance. There we are. So we've got a number of users of our system. The Lynn is a user. Some of these are brands that you probably will have noticed before. Victorian Order of Nurses, that's a fairly commonly understood national brand. That's a nurse, they're a not-for-profit homemaking and nursing company that works on contract. And then there's some for-profits that work with us as well. That's the scope. 19 public hospitals in our LIN. 1 community care access center, that's my customer, the CCAC. They're the special government agency that organizes, dispenses, and pays for home care. So what are we doing for them? Under the province's banner, it's called eShift. So if you want to capture that, what is eShift? It's virtual hospital care. It's the idea of extended shift nursing in the home, right, but delivered in a different way. So we're talking about patient care remaining under the responsibility of a nurse. So for the clinicians in the room, we're talking about a nursing care plan legally. This is a nursing care plan. But the nurse is remote. The nurse could be in Toronto and the patient could be in Grey Blue, suffering overmorning, which happens quite often. A nurse's aide or a personal support worker in Ontario lingo is at the bedside, working on behalf of the nurse. Now we don't transfer all skills and subsets to the nurse, or from the nurse to the PSW. Visiting nursing will still come in, but a very, very large amount of what's needed is being actually executed and done by a non-regulated staff member. And that's there's the disruption piece right there. So we're enabling a significant disruption. So the nurse is now acting as a delegator. So they're working remotely. We talked about the 3 M's. They monitor, they mentor, and they manage. So they're live monitoring what's going on. They're mentoring, they're doing knowledge transfer between themselves and these aides and the team. And then they go into management. They actually have command and control ability, direct traffic, and say, this is what you're going to do next, I'm going to follow up and watch, et cetera, et cetera. So we're talking about an enhanced skill aide working at the bedside, not in replace of a nurse, but in support of a nurse, with visiting nursing as the backup coming in and supporting them on skills that we can't transfer. So who are the patients? I mentioned that a little bit. We're focusing from a monetary standpoint right now on end-of-life patients and pediatric patients, but there's really a couple of fundamental things that when you look at the patient group, they don't technically require hospitalization, but that's where they get their care. So these are patients that normally get their care in hospital at a very, very high cost to the collective system, but don't actually need to be there. Their care plans aren't that complicated. They have a high preference to be at home. So we're talking about end of life. These are patients whose preference is to die at home. The ministry uses the term death with dignity in the place of choice. These are patients that want to be at home, but can't. And it's usually for 1 of 2 reasons. They don't have enough family support, and that doesn't mean they don't have enough family that loves them. That means physically they don't have enough family that can do the work that needs to be done. And or their clinical, their clinical situation, their comorbidities, the diseases that they're dying from, and the way they're interacting are dynamic enough that their symptoms are very hard to manage. And even if we had enough family members to take care of them physically, it's a moving target, and they're going to constantly be coming back to emerge because of symptom control issues. They're going to be in pain, et cetera, et cetera. So those subsets have a need both day and night. This isn't a 9 to 5. This is a 24-hour issue. So what do? That's the traditional model of care right there. And when we think about hospitals, we normally think about the cost from a community perspective. And people like to point fingers at how expensive hospitals are as a thing. And that's discounting a very fundamental piece, and that's the overhead. And when we're talking about community care, we're talking about your house. So thank you for paying your mortgage, we're going to provide care in your home, and we don't have to worry about the overhead costs. However, the community is incredibly inefficient. It is the most inefficient model of home care from a service provider standpoint, from an expertise standpoint, that nurse, that you could possibly have. Unless you have this strange and bizarre fortuitous clinical event where 4 people are all receiving care at home, motor vehicle accident, and the single nurse gets to show up and service 4 at once. Almost every time it's 1-to-1. You will not find a hospital environment, except for the ultra-high acuity wards in a hospital or resuscitation bays or during a code where you're going to have 1 clinician work with 1 patient. So that's the Achilles heel of community care. It's less expensive. The fixed resource is the nurse. That's the pivot point. That's what we had to bring. So what do? We talked about that enhanced skill PSW. They're given additional clinical training. So that's a PSW that's coming in and getting specific training around, for instance, end-of-life care for an adult, or pediatric complex care, how the machinery works, what they're going to do. They're the same skills that are taught to a competent family member. So we're not breaking any regulatory boundaries as we talk about transferring skills outside of the continuum of a nurse or a doctor to somebody else. This is no less than what we would teach a competent family member, a child being discharged with their parents at home. We're talking about insulin injections. An insulin injection is a delegated act, right? Giving yourself an intramuscular injection is an act. It is something covered under the act. That is a transferred skill. So they're given technical training and clinical training, which lets us set up a loop between that aide and that nurse. They're collecting clinical data that they often don't have any, doesn't give them any weight or have any significance for them, but presents incredible significance back to that delegated nurse who's remote. It's not just quantitative, it's also qualitative. It's no longer just about charting what would be in a normal traditional clinical chart. It's about the environment, what's happening, the coping, the mechanisms occurring around that patient's bedside. So when you think of an end of life, there's a lot of complicated stuff going on, social, psychosocial happening around that patient's bedside. Same with in peds. We're both talking about two very high-need patient groups. What we're doing is we're sending information up that lets a regulated on our end, who's also a subject matter expert. In this case, we now always have a palliative specialist or a pediatric specialist in that role as a nurse. Being able to look at a full picture situation and direct that PSW what to do. The efficiency that we've consistently been able to bring in is 4-to-1. So today, we have one nurse managing up to 4 beds at one time virtually. So that's the impact of the system that we've shown. As I mentioned, this does not replace a nurse at the bedside. There are certain skills, tasks, assessments, delegated acts that you would never send to a non-regulated professional, and the visiting nursing comes in and does that. It's very episodic and it's very focused and efficient, and they can come back out. They also come in and support in-service training of those aides, those personal support workers, to make sure their skills are up to par and they're doing what they need to do. What gets interesting on the clinical data side of things is now that we've cracked the code on that model, and we've got this data that's being used to support the decisions and the follow-up, etc., we're able to start to share that. Physicians are tying into it on a web portal. We have the CCAC case managers. Those are the government staff that actually direct and are the gatekeeper to your care, watching what these service providers are doing. There's a whole clinical analytical piece. And then on the other side, and this is an interesting space for us, is a caregiver or a family portal, where we're now tying in the informal caregiver into the process. So when you think about it, for us, the way that we see the ecosystem, we're talking about around that bedside, the people that need to make decisions about what's happening with the patient right now, the nurse, the case manager who is also a clinician, the visiting nurse that's coming in, the PSW that's at the bedside, and the caregivers supporting them to be able to do the work they need to do. But it's bigger than that, because around that, you've got all these tertiary users of that clinical data, both for the use of that patient, for their greater health system. Statistically, it spreads out quite a bit. So there's some interesting opportunities there. So what? So I've shown you some interesting human resources model, essentially, that we enable. That's disruptive in a lot of different ways. What's been the effect? For the CCACs, they're across the board showing a 4 times capacity increase on their specialist RNs. That's a huge thing for them. They've got to do more with the same amount. They don't have enough nurses to crank out. They know, and interestingly enough, they compete against the hospitals for staff. So when you see a large staffing drive at a hospital, usually those nurses are being pulled from community because they pay more in the hospital. From a system standpoint, one of the first studies that was done on our end-of-life patients. So the first 50 patients that came through, these were all patients that were end-of-life. They were on a do not resuscitate order, so they accepted that they were dying. They'd all put a patient preference to die at home. Every one of them was either in hospital or on a hospital care plan. Due to one of those reasons I talked about, they weren't going to be there. 95% of them, once in the eShift program, died in their own bed. So it was almost 100% turnaround from what was expected. 85% had 0 days outside of their bed. outside of their house for care. Some of them, 10% came and went and got some external care. That was at the beginning. The numbers now are pretty amazing. Our average admission rate is under 2%. So we're taking patients that we talked about at the beginning that were hospital-bound, hospital cared for patients, and we're at under 2% admission rate in hospital. So they're unchained from that bed and that clinical team, and that overhead, and that hospital. Organizationally, what's been really interesting is what's happened with the personal support workers and the nurses. It's very disruptive for the nurses, and then eventually they come right around and there's a high level of embracing because it's a great job opportunity for them. They love it. The opportunity to take physically worn out, I don't mean that in a diminutive, negative sense, but in your late 50s, early 60s, which is a lot of our nurses who are highly experienced. Bedside nursing by yourself in community is an incredibly physically challenging job, and there's a lot of nurses that can't bedside nurse anymore. The opportunity to put them into the system and have them sharing their information and their knowledge and reduce the brain drain is incredibly valuable to the greater system. The aides, the personal support workers have come up this full notch from being the orderly to being an actual partner in the care of delivery of somebody, and the knowledge transfer has been absolutely fascinating. There's been a number of studies that have started around that service model and that model of care and the impact that it's been having. A big part of what they're trying to figure out is why do we have a 1.9% readmission rate when the best comparative would be if I put a nurse at your bedside, we've got a 50% readmission rate. And the best that they've come up with to date is it's this new team environment, the level of transparency, and the opportunity for multiple eyes to be on one patient data set and be working around something with expertise in the middle and the opportunity to pull in other eyes when needed and actually make more effective decisions. That's the assumption. There's studies and tests being done on that now. When we talk about the performance and BI opportunities of what's coming out, we're talking about live monitoring. We're talking about an environment that previously you're a lone wolf. If I'm that clinician at the bedside, paper-driven, everything I need is in the back of the trunk of my car. The office gets a report at the end of the month. You as a remote family member, you're going to hear about it maybe, right? Now we're going to GPS tracking of every resource, live linkage of everyone, live data sets. Case managers are watching live everything that's happening. Family members are logging in and watching and reviewing the reports of everything that's occurring around their loved one. It's outside of that initial circle. When we move to the family side, it's patient-centric. The patient determines, or their substitute decision maker determines who has access, who gets to see what. So we've moved an entire paradigm shift away from where it was. This is an important piece. It's a new service model, not a technology fix. Our market position is enabling a new service model, not hustling software. And there's nothing wrong with hustling software. For us to be entrenched and to have long-term value, it's the fact that we enable a new service model, and we built domain expertise in that, and we're the partner in implementation for the ministry as they roll this out. So we have a value add. Someone can copy what we've done. They're going to do it. That's okay. We've got our strategies to make sure our technological feature sets are advanced, and we've got, that 1 to 2 year lead time on top of the guy that comes in behind us. That's our value proposition, right? Not whether we're an ASP platform or whether we're whatever. So it's a proven approach. Talked about adult hospice. I'm going to show you a little video to give you the human impact, and then I'll wrap it up. You'll notice this talks nothing about technology.
Terry Blackman's wife, Vicki, is in end-stage liver failure. And as her primary caregiver, he knows how difficult it can be to support a loved one who wishes to live out their final days at home.
I guess I've been a caregiver now for about 6 months, but about 6 weeks ago, I was starting to get very tired. I would be up 3 or 4 times in the middle of the night giving her something to drink or helping her go to the washroom or whatever. And I just was getting worn down, and so finally, one Sunday I just couldn't cope with it anymore, so I actually called 911, got an ambulance, and took her to the hospital. And they admitted her. I think she was there 8 days. And they put down the cause was husband not coping.
family members are tired, and so caregivers are trying to rest, usually on a couch close by, not in their bed, properly sleeping, and so both end up being awake a lot of the time.
There was times when, when I would get very tired, and then I would get almost angry, resentful at, you know, requests for something to drink or requests to go to the bathroom. And everything was getting on my nerves. Well, I don't have that problem right now, thanks to this eShift.
eShift is a new program funded by the Southwest Local Health Integration Network and coordinated through the Southwest Community Care Access Center. It means that specially trained or enhanced personal support workers, also known as EPSWs, are able to support people like Vicky in their homes overnight. The EPSWs are connected via an iPhone application to a registered nurse throughout their entire shift.
So I think that the technology really enables that constant conversation and communication back and forth.
I sleep better than I have in a long time. Just, you know, either 6 to 8 hours sometimes. I go to sleep when I get here, and sometimes they gotta wake me up and tell me they're leaving. I say, well, I've slept.
You don't do anything at nighttime. It's just wonderful.
Yeah, a few times she's got up at night and they've got her a bowl of cereal. I don't know anything about it. They tell me when I get up in the morning.
I think it's the most exciting program that I've ever led in 40 years of nursing. So that's pretty exciting.
It's just made a huge difference, huge difference. And I get a full night's sleep. I'm rested during the day, so I am able to look after my wife, Becky. And so she's getting good service at night, and I'm giving her better service during the day.
So for us, that's why we get up in the morning, and that's what makes it exciting for us to do this project. And that's the kind of impact we're having with, you know, every family that's in our system. We've had hundreds of end-of-life patients come through by now. We've had dozens of pediatric patients. They're a longer-term, you know, anywhere from a year to 14-year commitment to take them all the way through their limited life. The end-of-life patients, the auto end-of-life, that's a turnover, so we see that live. Not video images of them, but we watch the systems running. For us, it's transactional, so we can see a map across the province of where everyone is and what's going on. And that's a good news story. Sounds like a dark and depressing thing to say, but that is a great story. You're hearing about someone that was stuck in a hospital that came home to be with their husband, a husband who was able to take care of his wife and be there with her to the end, and do it in a way that was both supported by the collective, by our system, by us, and be a participant in it in a way that was cost-effective, sustainable, and long-term. So for us, there's been some interesting challenges. Happy to talk about those to those of you that want to chat after, have any questions, everything about how we, as we mentioned, HTX has been a big supporter of us and how we got where we are today and what our plan is to go forward. So happy to share that with you guys.
Yeah, actually, I was wondering what parts of the solution do you provide? Does it actually use like software, hosting, nurses?
So we supply everything but the clinicians. Everything but the home care provider themselves we provide. So everything from telephony to the data hosting to the web portals that everyone's using, to the mobile applications that the frontline workers are using. So we're soup to nuts. We didn't want to be, but when we started this, when we went live with this in early '09, so we signed a contract in '08, there was no one else to do it. So we really didn't have a choice. If we wanted to do the pilot the way that they wanted to try it, we had to give them everything because the infrastructure wasn't there for anything else. So.
Is it also the time moving forward?
For Ontario, yeah. For Canada, it makes sense. For the US, it's a little different. The US has the same need, but it has a different distribution model for end-of-life care. So it would be more likely in a US environment for us to transfer the technology into, for instance, Hospice of Michigan would be a good example. We're talking to you right now. They have 85% of the end-of-life market for the state of Michigan. They are unto themselves like a CCAC service provider. So transfer the technology into them. They would host and operate it themselves. You find for us going into the US, the level of technology uptake in the downstream service providers is much higher. So they're at a point in time where they get actually take it in-house and run it. You know, we have 24/7 help desk that's direct fed right to the frontline worker. They've got a button they can press that calls up their delegating nurse, calls us, and the three of us are on the phone at the same time. I mean us, I mean sometimes that's me. So, not to them though. Yes.
I'm just wondering, do you have any stat on what is the cost saving that this 100 patient brought? And also, who is of that financial benefit of the cost saving? You know, who gets benefited in the whole supply chain, basically?
So the cost benefit, you got to look at it in three different places. So the service provider, the end business, so there's three layers of money exchanging hands here. There's the home care company that's actually contracted to go provide home care. It's a revenue generator for them. This is a way that they can divert a patient from hospital, keep them at home, supply nursing services, and bill for it. So they're thumbs up on this. Right? The second layer is the CCAC. They're the government agency that's actually responsible for everything that happens besides what's happening in an institution. And that includes long-term care centers and home care. For them, they've got a mandate to basically opening up capacity to keep these patients at home and provide services. There's a net increase in spend for them overall because they're providing their service. Right? However, they're doing it at a lower cost because their previous way that they could do this would be direct nurse to patient, and they do that. The first patient that we brought on in peds had 14 years of an RN in their house, 8 to 10 hours a day, 6 days a week, for 14 years. An RN at the bedside. There's not enough RN, so there's not a lot of that going on, but it's happening. The third layer, if you look at the system standpoint, if you go up to the limb level, that's looking at hospital, home care, they see it as silos, kind of as clusters. They're the ones that see the biggest bang. For them, they see, okay, I got a palliative care bed, or I got a patient, and it's in an ALC status in a hospital that we should be discharging out. Right? They're here for these other support reasons down below. We can't kick them out. We can't move them down. They don't even want to be here. Right? We're not talking about forcing people out. Their average bed cost, and there's different numbers, it's well over 1,000 and it's under 4 or 5. It depends on what tests and what stuff and interventions are being done. That's where they start to say, okay, what's the right place for us to put our money? What's the bang for the buck? We need to keep these beds open for higher acuity, higher need. So there's an interesting lineup there. I've been chastised a couple times by using the word savings inside of ministry offices, and they didn't mean that when they said it to me in a negative way. They're like, we're not looking for savings, we're looking for efficiencies. There's a difference. Savings, we're taking money and sending it back. Efficiencies, we're doing more of what we have. So from a net spend standpoint, they save a ton, and they do a lot more than they were with the same dollar.
Do you have any challenges with respect to hospitals because their revenue is going down?
No, they're excited about this. If you take a look at an Emerge medicine, go to Emerge and ask them how much they'd love to see end-of-life patients coming in who have symptom control issues, and they show up and they've got a day and a half of trying to figure this person out, and the pain and suffering that that patient's going through, and the disruption to the family and everything else that's happening. If there is a way, A, for them to not be there, or B, when they present, to be able to have a concurrent list of everything that's going on, a full map to everyone that's involved in the care of the patient, and very quickly be able to determine what needs to be done intervention-wise to get them stable and get them back home, they're ecstatic. Anything that reduces that front-end load and increases their ability to discharge, they're not crying for people. We don't have Canadian hospitals short patients for the most part. Unlike some, and there's the difference in the U.S. There are different incentives. So there's some perverse incentives that occur in the States, especially around end of life, where it's an opportunity to jam service on somebody and bill for it. Any other questions?
Yeah, I have a question. So you present a new model of care. How much pushback did you receive when proposing the pilot?
We were approached to do the pilot by the ministry. We were presenting to them a model of care that was around physiotherapists and surgeons, actually, that would allow exactly what we were showing there, but for total hip and total knee replacement surgeries, etc. And they said, you do this for peds? And we were like, what? And then they told us the model, and I, as a project manager, like, you gotta be kidding me. We're going to take the most vulnerable patient population and try this with it? Sure, let's do it. And so it was their idea. It was their problem. We listened to them to tell us what was their biggest problem, and we helped them solve it. We retained the intellectual property rights to the So that's the way we went.
Okay, thank you, Patrick. That was a great presentation, fascinating company, and we just give a